Good morning, friends. In today's episode, we are proud to have the most talented faculty of India in infectious diseases, Dr. Dhanya Dharmapalan. She's from Mumbai. I think she's the only one with PG diploma in pediatric infectious diseases from Oxford, along with her MD in pediatrics, FIAP and FPIDS. She's a senior consultant in pediatric infectious diseases, particularly her interest is with the infectious diseases. She is attached with Apollo Hospital, Navi Mumbai, India. Her interest is antimicrobial resistance, antimicrobial stewardship, and polio eradication. All the important topics. For the pediatrician, Dr. Dhanya Dharmapalan is a leading consultant pediatric infectious diseases in India. She was trained in pediatric infectious diseases from Oxford University. I think she is the only one. She has designed and led the National Apollo Antimicrobial Stewardship Program for over 75 hospitals in India. Co-lead of Global Health Subcommittee of Pediatric Infectious Diseases based in USA since 2020 till date. Chair IPA Working Group on AMR 2023 and 2025. She is invited antimicrobial resistance expert by the Switzerland in Indo-Swiss Antimicrobial Resistance Dialogue in 2023 and 2025. She is an editor of 20 pediatric textbook and over 70 publication. Great. Great achievement, madam. She was honored as a fellow of Indian Academy of Pediatrics in 2018. She has become the first doctor working outside North America to be awarded the Fellow of Pediatric Infectious Disease Society USA in 23. Proud to have you on this talk show in this platform. I am sure that all the IAP member and the public will be benefited by her talk of today. Thank you. You are most welcome.
Thank you, sir. And it is a great honor for me to be on your talk show and to be able to reach out to so many colleagues. Just a clarification, there are definitely many more colleagues who have done this course from Oxford. But thank you very much for your kind introduction.
Madam, I never knew about anybody else. I knew only about you. So I mentioned it.
Yes, sir. So shall I share the screen?
Yes, yes, please. Welcome.
Thank you, sir. Uh, so today I felt the need to speak about what we can do as a pediatrician to combat AMR. And just few hours back, the World Health Organization has announced the theme for 2025 for AMR Week, and that is Act Now, Protect Our Present, Secure Our Future, highlighting the urgent need to address this problem. And why are we at all listening to this topic of AMR? Because it is relevant to each one of us, because AMR leads to treatment failure for the patient. It could make a situation helpless for us to save the patient as we run out of options to treat. It increases morbidity and hospital stay for the patient, increases cost, makes routine procedures risky, and makes complex procedures like transplant even riskier. And few months back, the top leaders of around the globe met in New York in the United Nations General Assembly. Historically, a high-level meeting, a full-day meeting on AMR was conducted by the United Nations. And even India is signatory to this political declaration which took place. They recognized AMR as one of the most urgent global health threats to human existence. And of these, I shall take your attention to this particular clause 64 under the human health, where there is a statement that to ensure by 2030 that the use of WHO access group of antibiotics is expanded. What is this access group of antibiotics? I'll come to in my presentation. Taking into account national context to achieve at least 70% overall human antibiotic use globally through investing in and strengthening stewardship programs. So I'll come back to this again, how we can achieve this. But why at all there's so much global attention is because it is estimated that by 2050, if we do not tackle AMR now, one person could die every 3 seconds. And how does antibiotic use drive antimicrobial resistance? So you can see in this diagram, in a population of bacteria, there are these susceptible which are marked in green and few resistant ones which are marked in red. And as per natural selective pressure, if an antibiotic is given, the susceptible die, but the very few resistant ones start multiplying. They not only multiply, they transfer their secret mechanisms of survival to other bacteria, and this also spreads into the community. And unfortunately, it's not about antibiotic use in human health alone, but its use in poultry also drives resistance. The disposal of antibiotics by the industry, by the hospitals into the sewage also contributes to antimicrobial resistance. So it is a major, a bit complex problem which requires multi-prong level actions at all levels. And there is enough evidence in literature that antibiotic use itself drives antibiotic resistance. As you can see here in the table, so we use cephalosporins, it leads to resistance. Then we use carbapenems, it leads to its resistance. Then we use colistin. But unfortunately, we don't have many options after that. So there's no secret about the rise of superbugs. It is man-made by feeding antibiotics. And as you can see the time trend that there was a period of dark ages where common infections could kill. But then the antibiotics came as a miracle drug in 1950s and 1960s. Many antibiotics were invented and discovered, and but unfortunately we could not cope up with the increasing antibiotic resistance. And you can see in the figure, the number has slowly declined, and we have only one few antibiotics, say 10 new antibiotics approved between 2017 and 2023, none representing a new class of antibiotic. So the question is, will we be going back to the dark ages where common infections could kill? And this is unfortunately not an imaginary situation. My journey with antimicrobial resistance actually started with this study thesis I did at Oxford under the guidance of Professor Mike Charland, a well-known global expert in AMR. And basically, we didn't have data of AMR in pediatric and neonatal population. And we looked at the literature published from India of past over a decade. And what was alarmingly found is that the resistance of common pathogens in sepsis to the WHO recommended first line, that is ampicillin and gentamicin, was very high. Say Klebsiella more than 95% and E. coli to ampicillin more than 92%. This was published later in 2017. WHO took a note and actually marked it as an editor's choice in its official letter, as well as the our government also quoted this in their scoping report on AMR. At the same time, we also pointed out that if we give a wrong antibiotic in sepsis in the start itself, the odds of mortality increases nearly threefold higher. So therefore, we have to be right at the very beginning of sepsis. Now, we have challenge of AMR. We need to be right with our antibiotic. Now, what about the viruses, fungi, parasites? Is there a problem there? Yes, there is a problem. Unfortunately, way back in 2009, children developed resistance. In fact, even more than adults, for oseltamivir for influenza. So that means it is not just antibiotics we need to take care of. Even fungus is the deadly Candida auris has caused a havoc across the world, and this is from Times of India, detected in Calcutta. This is 2019 article. Superbug Candida auris. And we are aware about the artemisinin resistance, and we share borders with countries which have a very bad situation of artemisinin resistance for malaria, which will threaten malaria elimination. So, WHO changed the slogan of handle antibiotics with care to handle antimicrobials with care, which includes all antibiotics, antivirals, antifungals, and antiparasitics. Now, what is happening in the diagnostics is that blood culture continues to remain gold standard, but we are living in a digital age where we need both speed and accuracy, and there are limitations agreed with blood culture, and there's a lot of progress in diagnostics. There is discovery, there's invention, sorry, of MALDI-TOF, MS. You can know the species, identify the species quickly. You may know the susceptible resistance pattern in few bacteria by use of molecular tests. Gene Expert has revolutionized TB diagnosis and management. So there have been some considerable progress, but at the same time, we still do not have an ideal test with a quick turnaround that you can immediately know whether it's a bacterial, whether it's a viral, which antibiotic it is susceptible to. So there are challenges for ASP, and in resource limited settings, there is lack of access to even basic existing diagnostic services. There's cost prohibition for additional tests. And there is unfortunate reliance on inappropriate, cheaper tests like Vidal test for diagnosis, say, of enteric fever. There's lack of trained personnel, lack of electronic records if you want to audit some data, and lack of incentives for setting up antimicrobial stewardship program. But irrespective of resources, there are problems which are not connected to resources. So at individual level, there could be lack of time. So antibiotics are basically used as safety net, so that one feels that I might miss a possible bacterial infection. So let me write an antibiotic and be safe. Lack of confidence, lack of awareness about resistance, poor clinical skills or knowledge, peer pressure. If I don't write an antibiotic, my patient might take an antibiotic from a doctor across the street who would claim credit for the cure in a possible viral infection, which anyways the fever will go in few days. So that fear. Patient pressure. My son has an exam tomorrow. Doctor, you write some antibiotic. Pharma influence. Unfortunately, the nexus with pharma industry is also to be looked at. So coming back, so then how do we achieve this target of more than 70% of access group, and what is access group? Now, WHO classified all the known antibiotics into these three categories. Access categories are those antibiotics which have low potential to develop resistance, and they are mostly recommended as first line for our day-to-day infections like amoxicillin, co-amoxiclav. So we are supposed to use more medicines from access group. Now, watch group are those antibiotics which have higher potential to develop resistance. And antibiotics such as third generation cephalosporins, meropenem, vancomycin, azithromycin, they belong to this group. Basically, we need to keep a watch of use so that they do not become resistant immediately. And reserve are those antibiotics which should be used only as last resort when you don't have any other options, like say colistin, tigecycline, linezolid, etc. Now, they have been put in these traffic lights. So you have green color, watch, yellow, and red for reserve. And
Mm.
WHO has published a very good antibiotic book based on these colors and indications, and they specifically talk immediately label the antibiotic which group it is from, and how the antibiotic consumption can be looked at. Watching this, using this, you can in a single snapshot know what is going on. So this is, for example, neonatal sepsis, and you can see that India's watch is around 30%. We have countries which have more than 80%, like say Switzerland. So basic aim is that overall consumption, it's not just for particular infection, but overall human consumption, which we don't have the data yet, of access group should cross 70%. That is our aim. And despite all the knowledge, there is some X factor by which irrational antibiotic is used. And I feel after all these years, I mean, we have had so many CMEs, we have good guidelines, we have good textbooks, but there is some fear factor, fear of the unknown, which makes a very knowledgeable pediatrician also write down an antibiotic irrationally. So I thought today, let me just talk about very clear situations where antibiotics can be avoided, and very clear situations where you need to give antibiotic. And these the examples that I have taken are not complex infectious disease cases. They are situations we see in our day-to-day practice, and believe me, these are the infections where antibiotics are most misused. So let me give a trial of how we can look at these situations rationally. So I'll start with when not to use antibiotics. So, a very common situation of fever, the clinical scenario is you have a child or adolescent who's active, the child is playful in between fever, good response to paracetamol, has generalized symptoms with fever like cold, cough, body ache, loose motions. The management should focus on explaining that this could be possibly viral, but should start spacing out maybe after 72 hours. You maintain hydration, report back if passing less urine or fever trend is worsening after 72 hours, or the child is lethargic in between fever, and give symptomatic relief like paracetamol for fever control. You don't have to rush to write an antibiotic here. Cold. In case it is short duration, watery or blocked nose, no tenderness over sinuses, non-sick looking, you can easily manage with saline nose drops. Use antihistaminics with caution in young with children. Cough. In case it is the cough is associated with general symptoms of fever, cold, the child is non-sick looking, there is wheeze on auscultation. In case of hyperactive airway disease, there's a history of intermittent cough episodes, especially worsening in the night. You don't have to write an antibiotic there. And you need to counsel regarding cough management, bronchodilators to be used in a wheezing child, and X-ray. If you suspect LRTI, usually a viral etiology, will have hyperinflated fields with a few bilateral infiltrates. Throat pain. So if it is associated again with cough, there's absence of exudates on examination or presence of ulcers, it usually indicates a viral etiology. So you ask to follow up if throat pain worsens, to look out for new development of exudates after 48 hours. Epidemiological background helps. So if there's a COVID outbreak, if it is an flu outbreak, it does help to and if there is, say, splenomegaly, in addition, you may consider even infectious mononucleosis and just do a simple CBC to look for absolute lymphocytosis. Now, if you have ear pain and it is unilateral, less than 48 hours of onset, the child is about 2 years of age, no systemic toxicity, all you need to give is symptomatic relief for the pain. You look into the ear with an otoscope and follow up if earache persists after 48 hours. Loose motions, if they are watery loose motions without visible blood, you just have to focus, counsel for maintaining hydration, explain the correct method for ORS preparation. Energy drinks are not ORS, may use probiotics or zinc supplementation. No need to do stool tests for microscopic blood if there is no visible blood and it's just watery. It's fine. Abdominal pain, the abdomen is soft and there's no localized tenderness, guarding, rigidity, and not associated with blood in stools, no systemic toxicity, you don't have to worry. You can, in fact, ask for other history, like say constipation, or you can give some antacids and manage appropriately. Now, when to use antibiotics? Because rational antibiotic practice is not about not using antibiotics correctly in viral infections, but also to use antibiotics appropriately in bacterial infections. So in OP practice, I'm again going through the same scenarios, okay, the same scenarios of clinical symptoms, but just I'm modifying the scenario where you can add antibiotic. So if the same child is sick or lethargic in between fever with poor response to paracetamol, here you would check for localizing signs. You would investigate the etiology because the child is lethargic in between fever. You could ask for CBC with smear. CRP can help in screening. The only viral infection which can create a confusion is adenovirus, which can clinically look like a bacterial, and even CRP can be more than 100. So epidemiological clue can help. Urine routine in case of fever without focus. Blood culture must be sent if there's clinical suspicion of a systemic bacterial infection. And as per the clinical clues, then you investigate for malaria, dengue, rickettsia, leptospirosis, etc. Do an X-ray chest if there's respiratory symptoms or PO. Sonography for localized findings in abdomen. If it is a PO, you may even go up to imaging or bone marrow examination. And for sick children, you admit and investigate. Cold. If the cold is long duration, if there's purulent discharge with tenderness over sinusitis, and you're now suspecting bacterial sinusitis, the child is dull looking, definitely here you would give an antibiotic, and the first line is amoxicillin, second line being called amoxiclav. Cough. Clinical scenario of cough associated with localized symptoms of fever. Child is not active in between fever. There are localized crepitations. Here you're suspecting pneumonia. The management is amoxicillin or second line co-amoxiclav or cefpodoxim. Do not use levofloxacin. Do not use linezolid or cefixime for OP management of LRTI. And for children above 5 years, consider macrolides for atypical pneumonia. Throat pain, if there are exudates, absence of cough, tender jugular lymph nodes along with it, then it fits into modified centers criteria where you are suspecting now a bacterial cause, and amoxicillin is the drug of choice, but the duration is for 10 days. And in case of systemic examination, again, revealing splenomegaly, do think of infectious mononucleosis and rule it out with the CBC. Now, ear pain, if it is bilateral, the child is less than 2 years, symptoms are more than 48 hours, the tympanic membrane is congested and bulging, definitely you start an antibiotic. Again, it is amoxicillin or co-amoxiclav. So please note, most of the antibiotics that I'm talking is from Axis group. Now, loose motions with visible blood in stools, or rice watery stools in cholera, or loose motions in sick-looking child or immune compromised, these are the situations where you would definitely give an antibiotic like cefixime or azithromycin for dysentery, maintain hydration, doxycycline for cholera. Abdominal pain, if there is localized guarding or tenderness, definitely you would probably do an ultrasound to rule out a surgical emergency like appendicitis, especially when there's disproportionate tachycardia, board-like rigidity, it becomes an urgent situation. Pain on micturition, if there is presence of fever, remember adolescents may not have fever, but rule out vulval rash because vulvovaginitis can cause pain on micturition and does not need an antibiotic. But you would do a urine routine to look for pyuria, and if there is pyuria, definitely send urine culture before starting antibiotic. Now, inpatient settings are what you need to question is, does this patient have an infection that will respond to antibiotics? Have proper cultures and diagnostic tests been performed? Can antibiotics be stopped or improved by narrowing the spectrum, what we call as de-escalation or change from IV to oral? And how long should that patient need an antibiotic? And you think about the post-discharge therapy. So the quick few tips for inpatient is, you need urgent antibiotics if you're suspecting sepsis or sick immune compromised host. You need to give broad spectrum coverage, but do send blood culture. Consider the empirical choice of antibiotic by what is the probable causative agent, where is the site of infection, what is the host immunity like, and is there an upright need for covering resistance, and how severe is the illness. Avoid antibiotics in case of dengue, uncomplicated malaria, influenza, or just because you have admitted a child for a possible viral infection like acute gastroenteritis. Avoid diagnosis of enteric fever based on Vidal. Avoid treatment of colonizers or contaminants, and beware of thrombophlebitis as cause of secondary fever before escalating antibiotics. And source control is essential. You discuss every day if you need an extra day of ICD, central line, or catheter, and you switch to oral antibiotics when stable or able to tolerate orally, except in meningitis, endocarditis, and neonates. And remember infection control and hand hygiene. But if the child is not improving, it could be a wrong antibiotic or a wrong diagnosis, like on infectious case. Now, so that's it about the tips. I tried in the COVID pandemic to circulate some WhatsApp tip for rational antibiotic practice. We also have published books, and of course, IAP is doing a lot for educating on rational antibiotic practice. This is a toolkit you will find on Pediatric Infectious Disease Society, where we have tried to build in, and you can see a lot about how to set up ASP. I've been part of the American Academy of Pediatrics policy statement too, but believe me, irrespective of which organization, which country, the principles of rational antibiotic use remains same everywhere. And we need to increase our public awareness, because unfortunately only 15% know what is antibiotic resistance. As IPA group, we made the comic story, but you can have these CDC charts, which are excellent charts, which you can download. We have Indian characters, posters with Indian characters. You can put it up in the OPD. Please, counseling is extremely important in day-to-day management. So, yes, definitely, rational antibiotic practice. Always remember to ask this question: is antibiotic needed? And if yes, you can write the indication and write the correct Ds, that is the right drug, dose interval, duration, and spend some time in counseling. I shall end my presentation with Mahatma Gandhi's quote: be the change you want to see in the world. Thank you.
थैंक यू सो मच धन्या जी, आपने तो कमाल कर दिया। 25
Thank you.
मिनट में आपने पूरा नॉलेज, यू हैव गिवन नॉलेज टू आईआईपी। मेरे ख्याल से इससे अच्छा कुछ हो ही नहीं सकता कि whatever you have done is really great, and IIP, IPA and IAP both are thankful to you, and from my heart I thank you very much being with us, and definitely the IAP member and will be benefited, and the public should also see that. But the only one thing I would like to add on it, that most of the antibiotics are used on the counter by the pharmacist rather than the pediatrician or the pediatrician, or by the other branches of medicine. They are
That's right.
using it, and we have no hold to stop them. And that is the duty not of IAP, but it is duty of the government to ban on the counter sale of antibiotic by, demanded by the patients. That is to
Yes,
be added, because our pediatricians are very sincere. But the thing is that what they cannot stop a counter in front of my clinic. I can't say anything because If I say anything to him, he will start talking irrelevant about me. So every practitioner is afraid of these pharmacists sitting in our country. But in US, I see that you can't get anything without the prescription. Thank you very much being with us. So, okay. Thank you.
Very much.
Thank you. I stop that.